Hello, everyone. Thanks for joining. This is Matt Sindred. I'm a doctor of physical therapy. I own my own practice called Star PTKC in Kansas City area. This course is an educational piece for patients and even physical therapists and physical medicine providers if you need to. But this is about hip impingement. What is it? What are the causes of the pain? And what are next steps depending on how much pain you have. So let's dive into this free content for you. So hip impingement is a diagnosis often referred to as femoral acetabular impingement, FAI. So it can be caused by structural changes, such as cam and pincer changes, which we'll talk about, or just mechanical reasons. One reason I see all the time for this is if I just took my finger and did this, I don't have any bony changes necessarily leading to pain, but I definitely have a compression issue, which is that impingement. So a lot of people do this because of what we call lower cross syndrome, which we'll get into later, which is a postural dysfunction where the pelvis is tilted forward. Okay, so in both cases, structural and mechanical, the tissue gets pinched or impinged upon, and usually the symptoms are in the groin, front of the hip. Sometimes they're in other areas. They can refer down the leg. But most of the time, if someone's sitting too long, they notice that they have pain in the front of their hips, sometimes clicking, popping, catching. So if you have symptoms like that, definitely this education is for you. Athletes, this is a very common thing with the athletes we work with, and we see surgeries because of this. So usually if you're having some of these symptoms, you want to catch it early and get some imaging early. Talk to your physician about that. So because if you let this go too long, it may lead to degenerative tearing of the labrum to where you're rubbing the tissue. I call it the butter knife on rope effect. So if I took a butter knife on a rope, it's not going to cut it right away, but over time it's going to degenerate and tear. So usually this happens in the front top of the joint. So when you're sitting and your hips impinge in the front or tilt forward, the bone and the bone together, impinge, and then they break down the labrum there. So probably the most common area for a labral tear is what we call the superior anterior part, which means the top front portion. So if you want to get diagnosed with hip impingement, physicians, medical providers, somebody that can diagnose. So PTs, we can do what we call movement dysfunction diagnoses, such as, hey, you have lower cross syndrome, you have a forward tilt in your pelvis that may be causing, your pain, but we cannot order x-rays or MRIs, so you'd have to consult with your physician. If an x-ray shows bony changes, then typically if you're having clicking and catching, the orthopedic doctor will order an MRI. I managed the clinic for 5 orthopedic surgeons for about 6 years, and we saw many of these cases where we would get images, they'd have small changes, but then they'd have a large tear and need surgery. We'd have cases where they had small bony changes and they didn't need surgery at all, because you'll see in the research that there's many people are walking around without pain, and if you image them, they have a bony change, one of these cam or pincer deformities, which are small. Small things shouldn't cause problems. Everybody has small abnormalities in their structure. So if you get an image and it shows small things, and your symptoms aren't constant and severe, then you're likely going to get better without any intervention other than physical therapy or exercise progressions. Most of those cases just need exercise progression and education, and we make progress without any manual work. So we'll go through that at the end of the slide and how that can help. So the other reason, again, if there's no bony changes, then the inflammation is likely due to the mechanical dysfunctions, such as weak glute muscles or core muscles. So again, in the example of the finger, if you think of the lower part of my hand here as the pelvis and the upper part is my trunk, if my pelvis goes forward and my trunk goes back, I would pinch my low back. Same thing happens below that at the hip. If my hip is in effect forward of my pelvis, then I get pinching in the front. So a common reason for this, again, posturally, the number one reason people have this issue when they squat, sit, is their pelvis is tilted too far forward. So pretty simple thing to diagnose movement-wise and posturally from a physical therapist. Actually, you can diagnose this on your own with a little simple education I'll provide you in a minute. So let's just go through the two types of bony changes. So if you ever get an image and you see this, a pinch or impingement or deformity, the bone extends over the edge of your hip socket. So you can see that here in the red. That's extra growth. So if the end of this, the neck of the bone or the femur, your thigh bone comes up like you're bending, those bones are going to come closer together. Again, you can cause degeneration of that cartilage that's around the rim of your socket. And then in 2015, there was a review of studies. They found the prevalence of pinch or impingements among roughly 2,000 people that did not have symptoms was 67%. So again, just because you have a bony change doesn't mean you need to hurt. We can actually, for most of our cases that do have pain, we can figure out strategies to get them out of pain and improve their symptoms fairly quickly with the right kind of program. A cam deformity is basically where the bony growth is on the neck of the thigh bone, the femur. And again, if those two bones come together, it's going to pinch, cause degeneration over time. In that same study, 37% of people without hip symptoms had a cam impingement. So again, I mean, you're seeing a lot of prevalence of these bony changes without people that hurt, and that's a very normal thing. We all have abnormalities in our joints from wear and tear, from activities. No joint's perfect. So the key is, if you do have pain, what do we do? How do you know how to get treatment? Again, just knowing that you have a postural problem could be the key. Another part of the study, soccer and martial arts, the most common activities in athletes with hip symptoms. And again, there's a higher incidence of these in athletic population without hip symptoms. So I work with professional baseball players down to younger athletes. I also, golf performance is one of my main passions. And so with those symptoms, with those types of clients, we do see these issues arise. We actually do assessments on all our athletes in our strength conditioning program, and I do catch people with these impingements that need follow-ups just on an assessment. So and it's pretty easy to identify who's can get better without intervention and who are the people that need to see the orthopedic doctor quickly. So there's also a combination, which again is between 13 and 44% have a combined combination of the two, because nothing's exactly one or the other. So let's say these two types of these two bony changes were very large, then more than likely you're going to need a surgical intervention, which they would just take these extra pieces of bone, shave them down, repair the cartilage damage, and have you do physical therapy afterwards. So there are a percentage of people that do need that. Usually those are the cases where they really can't flex their hip past 90 degrees without significant pain. There's definitely a bony block field. They don't have good range of motion rotationally. So there's some pretty classic signs that we can see. But again, majority of people that have this, if they're starting to have a little bit of symptoms and we catch this early, it's more than likely the postural things leading to the bone growth. Okay, so what are the mechanical reasons? Well, the most common, which the only one we really need to talk about, is what we call lower cross syndrome. So, and this is really common in our culture because of our sitting as we grow up. So this pattern is really where our core gets weak and the back of our legs get weak, or on the reverse side, our low back's tight and our hip flexors, the front of our hips are tight. So if my pelvis tilts too far forward when I sit or stand, then the bone comes closer together. And if that bone comes closer together to the other bone and it's there for too long, then I cause what that causes compression and injury to the tissue over time. Again, example would be if this is the front of my hip and I'm doing this, if I just hold that long enough, it's going to hurt and it's going to cause inflammation. And it's not a bony change causing that, it's the position I'm in. So how do you know if you present with a lower cross syndrome? Sorry for the little bit of blurry, but a lot of people that think they need to sit with their back arched backwards. That's not correct. Sticking out your chest. The top picture shows a person standing. So in this case, the hip flexors, the front of the legs are tighter and the back of the legs are weaker, causing the pelvis to tilt forward. That decreases the space in the front of the hips. And that can lead to, over time, compression and irritation of the joint. So many people with this pattern, again, and impingement, have more pain when they're sitting. So if you look at the sitting posture, the front of her hips are just bone to bone right now because her pelvis is tilted too far forward and her hips are bent up. So really, if you want to learn how to correct the most common reason for hip impingement anyway, which also causes lower back pain, you can check out my course, which I'll provide a link to right after this video. But in that, you can also have chapter 1 is free. It talks about lower cross syndrome, but then I actually go through exercises from getting out of that pattern to basic home strengthening to even some gym examples on how to get stronger. 90% of my cases with lower cross syndrome just need the education and exercise progression and they get better. And again, if you have front of your hip pain because of this pattern, you are going to improve from that course as well. And if you have lower back pain because you're in this pattern and you have front of your hip pain, that's not uncommon. I see that all the time in athletes that have very strong backs, very tight hip flexors. So what to do next? If your pain is severe and constant and you have very stiff hips, like you don't have much mobility, you need to consult your doctor, get some images to rule out whether or not you have that cam or pincer deformity. That's step 1. If you're not sure, I would still go that route. Just go talk to your doctor, say, hey, I'm having hip pain. Can you take an image? Depending on your age, there could be degenerative changes such as arthritis. But in reality, this FAI, this femoral acetabular impingement, starts in adolescence typically, and people will have symptoms usually when they're in their teens to 20s to 30s, depending on their activity level. It's great to catch this early because most cases when we catch early, just like anything, they don't need any invasive surgeries. We just need to get the posture and the forces that are leading to the bony growth to change. And remember, the bony growth, many people have some level of that without pain. So if you don't have a lot of pain, the first course of action should be correcting the movement and the mechanical reason. And again, the number one mechanical reason is lower cross syndrome. So I'll shoot the link to my course. It's a really great thing. I've seen a lot of cases of this, and the majority of time we follow this one simple progression of activities to get rid of that lower cross syndrome. I hope that you find this information helpful and it's going to help you, inform yourself to know what to do if you're having hip pain. It's a very common issue, so don't feel alone. Doctors know what to look for, especially orthopedic doctors, and most of them will prescribe some type of postural strength training before they would consider surgery unless the symptoms and the dysfunction severe.